Hello, everyone. Good evening and welcome to today's webinar. Just let me know in the chat if you can hear me fine and everything, and then I'm going to go ahead and get started with introducing Dr. Lodge. All right, thank you. Hi, so I'm going to get started and introduce Dr. Lodge. She is one of our ABPsi Student Circle advisors, and we're really happy to have her as an advisor. Tonight, she'll be presenting on two different things pretty much, and it's going to be part one because there's a lot that can be said about it, and so we'll get right into it. So Dr. Tania Lodge is the Clinical Director of Minority Behavioral Health Group, which is a community mental health agency in Akron, Ohio. She specializes in providing culturally specific mental health services, including mental health assessments, psychotherapy, supervision, consultation, professional development workshops, and continuing education training on cultural competency and culturally appropriate services. I'm going to let her explain to you all what BSA and OCT is. And so I'll show her to you all so she can get started with that. You can go ahead, Dr. Lodge, if you want to unmute yourself so that they can hear you. Cool.
Good evening, everyone. Thanks for having me. Special thanks to the ABPsi Student Circle for asking me to present this evening to talk about optimal conceptual theory. Tonight, I will be covering part one, in which I will focus primarily on optimal conceptual theory, and then part two at the end of next month, I'll get into the therapy known as belief systems analysis. So for the purpose of the day, I want to talk about optimal conceptual theory, but first I want to talk a little bit about Minority Behavioral Health Group, which is the community mental health agency that I work for. I am the clinical director, and this agency was established by Pastor Jeffrey A. Dennis about 20 years ago to provide services to an underserved population, in particular the African American community. And in doing this work, he recognized that there was great disparities as it relates to mental health diagnoses, mental health services, and how it was provided to the community. So he got a team of psychologists together who developed the Minority Behavioral Health Group. And in that, we have adopted Dr. Linda James Myers from the Ohio State University's theory, optimal conceptual theory. So I do want to talk about that theory. I am going to talk specifically about how that theory is applied in clinical settings. And I am going to speak from the premise of how we practice at MBHG, the supervision and training that we provide, how we engage in the theory and the therapy here at MBHG, and also the research. So although we are using this theory and we are practicing this theory, there's also a lot of research and outcome data that we are collecting to help solidify the effectiveness of this type of work. So I'm going to go ahead and share my PowerPoint so we can get started with the topic.
And I just want to remind you all that as Dr. Lodge is presenting, you can go ahead and share your thoughts and questions in the chat box, and I'll be watching those, and at some point she'll pause for questions, and so I'll tell the questions to her because she can't see them while she's presenting, so I'll just be monitoring those and then let you all know. Yeah, feel free to engage in the chat box and I'll let her know. Thank you.
Are we ready?
Yep, go ahead. We can hear you.
So I have 3 objectives for tonight. Particularly, hopefully, you will get an increase in knowledge of optimal conceptual theory. You will walk away learning how to actually apply and conceptualize cases using optimal conceptual theory and applying it in a therapeutic setting. And overall, the goal is to help increase awareness, knowledge, and skills, applying culturally specific assessment and interventions. Now, whenever I do this talk, I always like to give a little background as to why this particular theory, why MBHG have adopted this theory, and why we choose to use this theory in our clinical work here in the clinic. So when we look at Western theories being those theories that we all learn in our graduate programs that tell us how we should think about clients, how we should think about client problems, how we should think about relationships, and how we should think and feel about ourselves in general. We learn these Western theories in school, and we are actually told that these are the theories that we should practice with. In fact, there's licensure exams, there's things we have to do where we have to learn these theories and actually use them and show competency in these theories as it relates to working with everyone in general. However, when you look at the research related to how Western theories are limited as it relates to the African American community, there are several discrepancies. And in fact, what the research will demonstrate and show is that these theories are not helpful at all. The first critique of Western theories, and when I'm speaking of Western theories, I really want to highlight the evidence-based practice movement, which we hear a lot about. All agencies, all practicing clinicians want to be competent and use what they refer to as evidence-based practices. Well, Western theories, i.e. evidence-based practices, tend to neglect the cultural view of minorities, in particular, people of African descent, the African American community. When we talk about neglecting the cultural view, the cultural experiences, the daily living experiences that the African American community is often faced with is not talked about, is not considered, is not discussed. And when this happens, we then find premature termination. We find that African Americans in particular are over-pathologized, meaning that they are often misdiagnosed. They are receiving less preferred diagnoses and treatment. So when we're talking about less preferred diagnosis and treatment, African Americans as a whole are often over-pathologized with diagnoses that consider psychosis, schizophrenia, schizoaffective disorder, antisocial personality disorder. These diagnoses carry significant limitations as it relates to the African American community. People who are diagnosed with schizophrenia are then asked to take psychotropic medication, antipsychotics. Then we get into scenarios where there's refusal to take such medication because they don't believe they have these diagnoses. Then they're called resistant to treatment. There's non-compliance. And when you think about the implications of diagnoses of schizophrenia, the population is often homeless. They're not able to be employed. There's several psychosocial barriers that play into effect when we have such diagnoses that is not matching up with the experiences of the African American community. When we talk about antisocial personality disorder, it has a criminal attachment. Individuals who are involved in the legal system, who are involved in crime, et cetera, are often diagnosed with antisocial personality disorder. African Americans overrepresented in that diagnosis, and the treatment for that is very punitive. You will find that we receive harsher punishment, often end up in jail or prison. So the importance of the background, as I'm talking about optimal theory, it's important for me to highlight the limitations of Western theories. Because when I get into talking about optimal theory, we're going to talk about oppression and how oppression really exacerbates, contributes to, or maintain the psychological distress that African Americans have. And so at a start, when we consider Western theories and the impact that Western theories have on the African American community, it contributes to the overall oppression that we see just from the daily living experiences of the African American community. So it's important that we hold this information prior to engaging into exactly what is optimal conceptual theory. So I always like to start with the background just to give us a premise and a framework that we can begin to see why this particular model is effective for people of African descent. In response to the limitations of the Western theories, back during the 60s and during the civil rights movement, African psychologists, African scholars got together and decided that it was time to develop theories and therapies and treatment for our people. The limitations were so great as it relates to the Western theories that there was a need to move forward to developing our own organizations, our own agencies, our own treatment modalities, and our own theories that will assist us understand the genuine experiences and the cultural considerations that is needed when we're trying to make sense of how we are understanding ourselves and our relationships with others. There was a strong need to really understand and treat clients of African descent from an African-centered worldview and philosophical perspective. Consistent with the African psychology movement, there was a major advancement in the multicultural counseling movement as well that highlighted the need for consideration of worldview. Research on the construct of worldview and how knowledge and understanding of client worldview leads to more effective, ethical, sensitive, and client-specific counseling and development of interventions. So we have the need to understand client challenges through an African-centered worldview. And then we also have a need to really hone in on the concept of worldview and how to really understand how worldview plays a role into how we see ourselves and how we see that of other people. Tons of research that I'm going to get into talks about how deviation from an African-centered worldview could result in psychological dysfunction. Before I get into the research, I want to talk specifically about what I am referring to when I'm referring to worldview. Oftentimes, worldview is used interchangeably with thoughts and how we think. And what we know as it relates to some theories, there's a greater emphasis on how you think. You change your thoughts, your world would be better. When we're talking about worldview in this context, we're really talking about a deeper understanding of self. We're talking about 4 philosophical assumptions as it relates to how do you see your existence? How do you see your relationships? Where do you place your highest value? How do you think, your type of logic? So when we're talking about worldview, we're talking about 4 philosophical assumptions that really tap into how we see our existence, how we see ourselves, how we obtain knowledge, where we place value, and the type of logic that we hold. The importance of worldview helps influence our thoughts, behaviors, feelings, our career choices, our life decisions, our relationships. The worldview is really the lens in which we see the world and our place and existence in the world. So worldview is at the catalyst of what we want to understand when we are attempting to understand people and the challenges that people are faced with. So worldview is a deeper philosophical construct. It goes way beyond our thoughts, behaviors, and feelings. In fact, the worldview is what drives those thoughts, behaviors, and feelings. And I'll unpack that a little later in the PowerPoint. To talk a little bit about African-centered approaches, there are tons and tons and tons of studies that I'm aware of. For the purpose of this talk and limited time, I can't cite everything, but I did cite a few that I'm aware of. And basically, what the research says about African-centered approaches is that it serves as a protective factor for people of African descent. Several studies have been done that highlight the importance of adhering to an African-centered worldview. Basically, what happens is individuals who endorse an African-centered worldview are less likely to experience psychological distress, whether it's depression, anxiety, paranoia, etc. And when they do experience psychological distress because life happens, they are more likely to cope. Nebler et al. 2010 did a study with college students. The Worldview assessment was administered along with a symptom checklist. The study found that college students who endorsed an African-centered worldview were less likely to experience depression, and they were more likely to find healthy coping mechanisms. Millett found very similar. He administered a worldview to university students, measured against a depression measure, basically found that the lower the African-centered worldview scores were, it was associated with greater depression. So again, there was a correlation between African-centered worldview and symptoms of depression. Then we have Hatter and Oddens, who also conducted a study and found that an African-centered worldview was positively correlated with academic and personal emotional adjustment in a sample of college students. I'm talking specifically about college students and the adult population, but again, there are also several studies that highlight the protective nature of an African-centered worldview for youth and adolescents. Tons of studies that talk about how they are able to adjust academically, they receive higher scores in math and reading, and how they just do well overall in the school setting when they are adhering to an African-centered worldview. So now I want to talk about optimal conceptual theory, which was developed by our own elder, Dr. Linda James Myers, who's at the Ohio State University. This theory clearly is grounded in African psychology and philosophy. What we like about this theory in particular is that it examines the history and oppression of persons of African descent. What Myers is suggesting in this theory is that psychopathology is a result of having a suboptimal worldview which promotes various forms of oppression. A suboptimal conceptual system creates a way of thinking and view of being in a world that is oppressive and the cause of mental or physical pathology. Essentially, what Dr. Myers is saying from a clinical standpoint is that the reason that we are experiencing the level of distress to the degree that we are experiencing distress is because we live in a world that is oppressive, and the oppression is causing the psychopathology. So I can't emphasize that enough. What Myers is suggesting is that the psychological distress that people of African descent is experiencing is a result of living in a country that is oppressive, and that oppression is what is causing the psychological distress that we see within ourselves and within our clients. Optimal conceptual theory requires a holistic, integrative, multi-level therapeutic approach. It basically holds that having an African-centered worldview is characterized by a non-material, spiritual reality that places emphasis on character traits opposed to more material or external criteria. Gaining knowledge results from a process of active engagement in which we are able to confront challenges, which is often seen as opportunities for growth. Optimal conceptual theory promotes social change for all oppressed groups, and the ultimate goal is to enhance pure knowledge and increase positive human relational capacities. In optimal conceptual theory, here's a significant part that I think is important for us to be aware of, because this is capturing the worldview component. Myers contrasts what is considered an optimal worldview versus what is a suboptimal worldview. The optimal worldview, being the African-centered worldview, is a worldview that is holistic. It does not separate the physical, the spiritual, your affect, your behavior, your entire existence is considered and is equally validated and discussed. Reality is known in the both material and spiritual fashion. Highest value is placed on interpersonal relationships, cooperation, communalism, and harmony with nature. Logic, in terms of how we tend to think and make sense of the world, is from a diunital perspective, both and. Identity is through the extended self. We acquire knowledge from an African-centered worldview through inductive synthesis and self-awareness. And our sense of worth is based on what is happening intrinsically inside of us. So from Meyer's work, an African-centered worldview is one that is holistic, non-material, non-competitive, values interpersonal relationship, has a logic that is considered both and. Knowledge is acquired through inductive synthesis, and our worth is defined by our intrinsic self. On the suboptimal side, which is a Eurocentric worldview, the worldview is segmented. Reality is known only through the five senses. Values, acquiring objects, competition, individualism, and control over nature. There's dichotomous thinking, that either or, black or white thinking. Identity is defined as the individual self versus the collective. Knowledge is gained through counting and measuring, and the sense of worth is based on external criteria. So essentially, what optimal conceptual theory is saying is that for individuals who hold a suboptimal worldview, they are at risk of experiencing psychological distress, just given the nature of how society is stratified into different groups. When we're talking about oppression, we're really talking about how individuals have a set of advantages based on a cultural group that they may belong to. So that's what optimal conceptual theory says in a nutshell. So what I want to talk about is how do we apply this in a clinical setting? So remember, the gist of what I would like for you to walk away with as it relates to optimal theory is that oppression and the worldview are the focal points as it relates to how we want to see individuals and what that means as it relates to their experiences. In the application process, there are 5 things that we tend to focus on. There's awareness and consciousness, there's the assessment phase, and the conceptualization phase. Diagnosis and treatment, we'll see that a little more in part 2. But for this evening, I'm going to touch on the importance of awareness, assessment, and conceptualization. In step 1, awareness, going back to the background, and when I talked about the challenges with Western theories, it's very important that we as clinicians understand the challenges with the mental health delivery system as a whole. There's a cyclical process of oppression that happens. When we think about how diagnoses are rendered, how the African American community are often misdiagnosed with something, when we capture clients' experiences in clinical documentation, and that documentation is subpoenaed into court or is subpoenaed into some kind of human services meeting, there's implications as it relates to how that information is seen and consequently how individuals are treated moving forward. So the first thing that we must do and understand as it relates to applying optimal conceptual theory, there has to be a level of awareness of the challenges with the mental health delivery system. The reason that that is important is because if we know it and we understand it, then it's going to be second nature to understand what it is we're looking for when we're looking for challenges that our clients are presenting with. The second thing that we must be aware of is the lived experiences of the community members that we are servicing. What are their lived experiences? Is it poverty? Is it violence? Is it broken families? What are we dealing with? And again, if we understand what we're dealing with, then we're going to know the questions that need to be asked and where that fits into the theory, and then how we move forward. Training. This is our individual training. How have we been trained and socialized to think about the African American community? How have we been trained and socialized to intervene, to treat? Are we contributing to the oppression by using Western theories on a population that is not meant for? Or are we going to do something different that's going to be liberating and uplifting to the community that we are intending to service? So an awareness of our personal training and how that training is influencing how we see clients and how we then treat clients is very important for us to understand. Lastly, the theoretical orientation that you hold. Do you know what your theoretical orientation is? Do you know what your theoretical orientation say about African Americans? And do you know what the limitations are for your particular theoretical orientation? Again, it's important that we understand these dynamics and have an awareness of this prior to even engaging in this type of work. And the reason being, in my experience and in some of the research that I've done, is if we don't have this level of awareness, by default, when we are working with clients and we are bumping against the challenges that they are facing, by default, we go back to what we were socialized to do and socialized to believe in particular about the population, and then what to do about those services. So we intend to be more African-centered in our approaches, but if we don't understand the real limitations of the mental health delivery system as a whole and understand the necessity of using African-centered theory, then by default, we often resort back to what we were socialized and trained to do, which again holds negative outcomes for the African American community. So step one is about a level of awareness. So that's internal work, that's self-awareness that we must do before we can even engage in this type of work. Step two is when we get into the assessment. When I'm speaking of assessment, I want to know specifically, what do you want to know and why is that important? We often don't know what we want to know. We often just listen to what people are presenting with or what we're being told. But what is it, given everything that you've been told and what the client has said to you, what is it that you want to know and why is that important? Again, this is a discovery of self-assessment also, because it helps drive what you want to do next. So step two is assessment. What optimal conceptual theory would say is, we want to know about oppression and worldview. Why? Because the theory holds that oppression and worldview is the reason and contributing factor or the exacerbating factor as to why we are sitting where we're sitting today. So we want to know from this theory, we want to know about oppression and worldview, regardless of what is being presented and everything that's being presented. I want to tease out the systems of oppression, and I want to be able to say the type of worldview that the person is holding that may or may not be impacting their psychological distress. So oppression, when I speak of oppression, what I'm talking about is a system that maintains advantages and disadvantages based on stereotypes, social groups, and memberships. Oppression operates on the individual, institutional, and social cultural levels. It is structural. It's not the result of a few people mistreating others. Essentially, anything that ends with ism is considered a form of oppression. So we're talking about racism, we're talking about sexism, we're talking about heterosexism, we're talking about classism, we're talking about ageism. So these set categories that society has structured put individual in certain groups. And given your status in certain groups, you either have a set of advantages or a set of disadvantages just based off of the type of group you are associated with. Having that happen creates a system that allows for people to have things and others to lack. That's considered oppression, which again creates depression, anxiety, addictions, hostility, paranoia, violence, et cetera, et cetera. The most insidious form of oppression that I like to talk about and how we see the clients here at Minority Behavioral Health Group is through internalized oppression. Internalized oppression is basically when we have bought into what we have been told from the oppressor about who we are as a people. So when we believe as a cultural group that we are unworthy, when we believe that we are inferior, when we believe that we can't achieve, we can't get a good education, we can't have the same things, this creates internalized oppression. And when we see internalized oppression, that's when you see depression, powerlessness, domestic violence, substance abuse, low self-esteem, et cetera, et cetera. So when clients come into the office and they're presenting or if I'm out and someone is staffing or consulting on a case and they're discussing client concerns, the lens in which I see that based on optimal conceptual theory is a form of internalized oppression, or it could very well be systematic oppression, institutional oppression, etc. The acceptance by the marginalized cultural groups of the negative societal beliefs and stereotypes about themselves. That is a significant barrier and challenge that we often see here in the African American community. And optimal theory provides a lens to help us to understand that and to also resist it so we can have better outcomes health-wise. The first thing that I want to talk about under the assessment process is the belief systems analysis scale. This is actually a scale that was developed by Dr. Myers and other colleagues to help measure worldview. So there's an actual scale that goes along with this theory to help us get some insight into the worldview that the person might hold. It is a 31 item 5-point Likert scale assessment. It measures worldview, particularly adherence to an African-centered worldview. This measure has been used in most of the studies that I've cited earlier, and we do use it here at Minority Behavioral Health Group at intake. One of the things we do is at intake, we give this assessment. The therapists have the assessment, they get an understanding of the worldview. Of course, that's processed more individually with the client, but then this assessment is used throughout therapy to help measure progress and to gauge how the therapy is working. Low scores reflect a Eurocentric worldview. High scores on this scale reflects an African-centered worldview. Again, this assessment is used as an outcome measure pre-post. We administer it at intake, it's done annually, and then it's done at discharge, again, as a tool to help us measure how therapy is going. Worldview, we want to understand from our perspective, and we want to help clients to understand if they have a worldview that's suboptimal or optimal. The way that we further explore this is helping them to understand their view of self. How do they view themselves? How do they view others? How do they view themselves in connection with others? Where do they place highest value? Is it on material things? Is it on interpersonal relationships? And then we also assess the BSA principles that I'll talk about momentarily. But any questions related to their identity, purpose of being, human nature, the role of their consciousness, responsibility is fully explored. And all of these questions and information that we gather at the assessment phase helps us to get insight on the type of worldview that the client holds. The BSA principles are spiritual development, intrinsic self-worth, extended self-identity, diurnal logic, self-knowledge, and holistic worldview. These principles are used in the therapy in particular to help intervene. However, we are also looking where clients are as it relates to these ideas early on in the treatment process. So a part of the assessment phase, we want to know how individuals see themselves spiritually. Where are they spiritually? What are their spiritual beliefs? We also want to know how they see themselves, their intrinsic self-worth. Do they define themselves by their purpose, by their divinity, or are they defining themselves by material things and objects that you can see? Do they consider themselves part of a community, their family, the ancestors, the yet unborn, or do they see themselves as just an individual? Is their logic diurnal, where they can consider both and, or is the thinking more black and white, either or type of perspective? We want to know, how do they know what they know? Where is their knowledge coming from? Is it from their intuition? Is it from their own experiences? Is it from their history? ancient African history, or is it based off of what they've been told and socialized to believe? Their worldview, is it segmented or is it holistic? So again, from a theory standpoint, we want to understand where clients are as it relates to these different principles that help solidify where they are in their worldview and if any work needs to be done in a particular area. Step 3 in application is conceptualization. This is where we begin to understand what the clients are presenting. What is your understanding of what is happening? Did you consider context? Did you consider worldview? Did you consider oppression? This is what optimal theory wants to know. When you are writing a conceptualization or you're thinking about a case and you're trying to come up with a treatment plan or a diagnosis or a way to intervene, that's fine. Do you consider context? Can you talk to me about the worldview and the impact that the worldview is having? Can you talk to me about the different various forms of oppression and how that's also playing a role? This is the difference with optimal conceptual theory. We must understand context, we must understand worldview, and we must understand oppression if we really want to be liberating and uplifting and help the African American community resist the impact that oppression has on us. I don't talk a lot about diagnoses here, but I do have it here because it is a critical part of the process. What I want to say about diagnoses in particular is that having a theory that help us to consider context, to consider worldview and oppression will more likely change the direction that a diagnosis is rendered. For example, African Americans are least likely, per research, are least likely to be diagnosed with depression and anxiety disorders. However, given the climate of the country, given the levels and various forms of oppression that the African American community experience, it's reasonable that we would see more depression and anxiety because it is depressing and it does cause worry and stress when we're dealing with poverty and dealing with violence and dealing with broken families. It is depressing and it is anxiety provoking. It doesn't mean that we're psychotic or that we're antisocial as it relates to our diagnoses. So diagnoses are important, but what Dr. Myers talked about in particular, she proposed a model that puts less emphasis on diagnoses because again, it limits our ability to see the context of what is happening, the social context of what is happening. So when we limit individuals to a diagnosis, unfortunately, which is what the mental health delivery system does overall, then it becomes limiting to how we see the clients and the clients' problems, which again has a significant impact and negative outcome from African Americans. So I'm going to pause here for questions. I think I breezed through that quickly, but here's a point of discussion. So I am open to questions at this point.
Okay, Dr. Lodge, one question that Brittany asked is, how receptive have clients been to OCT?
Clients have been, the question was, how receptive have clients been to OCT?
Yeah.
I would say that clients are very receptive to OCT. And my response is based off of our waiting list here at Minority Behavioral Health Group. It is the model that we use, is what we do our training and supervision on. We have a waiting list. We have over 600 clients total, and we have a waiting list of organizations attempting to partner with us as well as individual clients. Our clients are long-term. So we don't see the premature termination rate that we see, and what research would say is that African Americans do not engage in treatment, and when they do, they terminate prematurely. Well, we don't see that here at Minority Behavioral Health Group, and we attribute that to Dr. Meyer's work with optimal conceptual theory.
That is a really long wait list. Are those people who are within the community, or do you also have people that receive services online from out of state?
No, it's all community-based. So we are a community mental health in Akron, Ohio. We do have a couple schools in Cleveland. Primarily, our services are delivered in the local school system. So we have a high population of children and adolescents. In the community clinic, we do see primarily adults and kids who are not attached to the schools. And so, yes, everyone is local, whether they're from Northeast Ohio, Cleveland, Akron, Canton. We've serviced people in Columbus, Ohio as well. But currently, yes, nearly 600 clients active and a waiting list.
So there don't seem to be other questions coming up in the chat, but okay. I was going to ask my question, but I'll go ahead and ask. Someone just asked something.
Okay.
Are you suggesting there is no value in Eurocentric theoretical orientations such as dialectical behavior therapy or cognitive behavior therapy or other ones that you could think of that are more Eurocentric?
Yeah. I am not suggesting that there's no value. What I am saying is that they have limitations. And so if we are using those modalities solely, then we are doing a disservice to people of African descent. We do use DBT skills here. There are some other things that you can use, but any modality that does not consider the African American experience, a modality that does not consider the cultural background and cultural makeup of the individual, are significantly limiting. And again, it results in less preferred diagnoses, less preferred treatment, early termination, and a lack of engagement in the services altogether. So there is some value, sure, but to use those different things solely are limiting for people of African descent particularly.
That makes sense. Does that make sense to the person that asked the question? Also, Dr. Lodge, you could stop sharing the screen if you would like to.
Okay.
Another question that came in. So this person has two questions. I'll ask the first part. How can someone who is not in Ohio be trained in the belief system?
You come to Ohio. So, and I'll say this, we do trainings here. We do open it up. We just had visitors from the UK a couple weeks ago who came to Minority Behavioral Health Group to be trained on optimal conceptual theory. We do present every year at ABPsi on optimal conceptual theory and belief systems analysis. So we do travel. We present at the national conference. We do offer trainings here, and we're going to do that more often given the need and the request. But you'll have to come to Ohio for now until we can work something else out.
Okay, and I'm going to skip the second question for now, Dr. Jonathan, just to go to the one that says, are there any requirements to learning this theory?
There is. That's a great question. And I really talk about the requirement when I do part 2 and we talk specifically about the therapy. But Dr. Myers talk about prerequisites in doing this work in particular. And basically what she's saying is, if you don't live by this model, if you don't believe in it, if you don't practice it, then it's not likely that you will be able to do it. And so the reason that we start with theory and put so much emphasis on the theory is because if you don't hold the theory, you're not going to be able to do the work. the theory is very important in understanding. If you don't understand oppression, and if you don't believe that oppression is impacting, maintaining, or exacerbating the mental health distress that we experience, then you're not going to be able to do the work. If you don't see yourself as being exposed to or experiencing levels of oppression and going through your own work and process, then it's going to be very difficult for you to genuinely engage in this type of work and do it. So yes, prerequisites is that you have to live by this motto. You have to believe in it. You have to practice it in order for it to translate genuinely, spiritually, when you are working with other people.
And then a follow-up to that is this something that you have to be trained in to be able to apply it or to apply it?
Absolutely. Not only do you have to be trained, so I want to say this, a training is not going to do it. It's a lot of personal work. And it's difficult because, again, what Myers talk about is while you are helping someone and you're raising their level of consciousness, you yourself is also going through your process at the same time. So it's this symbiotic relationship and reciprocal process that is happening between the therapist and the client. And so you have to be comfortable with affect and things that you are experiencing in order for you to understand it and help other people work through it. So there's training, and then there's a developmental process that happens over time. And I would say working at Minority Behavioral Health Group for 10 years and actually doing research here on the staff and how they learn optimal theory and attempt to apply it, everyone is at a different developmental phase, and it has been a process, a long-term process, because it's constantly evolving. So it's not like you can go to a training and say, yes, I got it, I can do OCT BSA. That's not likely. You have to be comfortable with the challenges. You have to have supervision that's going to parallel the process for you, that can help you grow and develop as well. So it's a long-term process. It's a long-term developmental process that is ongoing. So yeah, you start with training, multiple trainings, but there's a lot of individual and collective work that happens at the same time.
Cool. And then the second question that Dr. Johnson had is, how might BSA be used with Black people with intersectional marginalized identities? And specifically, he was referring to racial and sexual minorities. So I guess you can start off with that or answer generally, but that's something that.
Yeah, so the model, the theory talks about all oppressed groups. So regardless of how we're identifying with ourselves, whether it's racism, whether it's sexism, whether it's heterosexism, the model helps us understand the impact that institutional oppression has on us. It also understands how we've internalized that oppression, and now how our view of self has been shaped, how our values have been shaped, how, we view our relationships and connections with others, how that's been shaped. So the model doesn't discriminate against individuals or people. In fact, it does the opposite and allow us to see how oppression has basically categorized us and has marginalized us into certain categories where there's certain things that kind of take place. But again, what I would do is I will help individuals see how they've internalized that oppression and how that is impacting them in their worldview. So that's how the model works. How is what you're presenting captured in the lens of oppression, whether it's institutional, whether it's internalized? What has it done to your worldview? Is your worldview suboptimal as a result? Is it optimal? And then that kind of give us some leeway into how we work. When we talk about the therapy in particular, I only talked about optimal theory today, and that's on purpose. But when I talk about belief systems analysis, that is the actual approach that helps maneuver a suboptimal worldview to a more African-centered worldview. So you'll see that process unfold when we get into the actual therapy. But as it relates to the theory is all about oppression and worldview. Oh, and I failed to mention that it examines our history. Historically, when we think about the historical injuries that has happened and then how we see some of those injuries play out in modern time, that gives us an avenue where we can provide education and discuss and an opportunity to raise the level of consciousness about how that happened. But we don't just talk about historical injuries, we also talk about ancient African history, where civilization began, where we place value on communalism and interpersonal relationships and a higher power and our spirituality, etc. So we talk a lot about ancient African history. We talk about the period of enslavement and colonization where historical injuries were instilled upon us, and then how we see some of those same behaviors playing out in modern day times. So the theory allows us to explore and understand those different experiences, which then gives us a lens as to how we see clients, and it allows us to not further oppress or marginalize our people given how the traditional mental health system is set up. Now, I know that was a long-winded response, but I failed to mention that earlier.
Yeah, well, if somebody has a follow-up to that, that would be, that's a good point of discussion. Brittany, I'm going to skip your question real fast because Dr. Lodge, you mentioned about modern times, and someone, Jocelyn, has a question about how BSA illustrates or for our teens, how oppression colors their life experiences in the present day.
Say one more time. I didn't get the full question.
Mm-hmm. How does BSA illustrate for our teens how oppression colors their life experiences?
How does BSA color? So BSA is the therapy that we didn't talk about today. So I'll go back and talk about optimal theory. And so the reason I'm doing this intentional because I want us to hold the theory today. And again, what happens is it gives us an avenue to explore our history as it relates to ancient African history, our history as it relates to the historical injuries, and it allows us to see how those experiences have shaped and socialized us, which is where our worldview comes from. Worldview is shaped by the different messages that we receive, whether it's from our schools, our families, our peer groups. We are socialized to believe a certain way about who we are as individuals, what our purpose is, where we place value, and etc. That's how it's shaped. And so optimal conceptual theory provides a lens for us to be able to have a discussion about where this comes from and how it's impacting us, which then allow us to resist or make needed changes where we see fit. It is up to the person themselves to determine the level of work that is going to be needed when we do get into the therapy, because they'll see for themselves, oh, my worldview is more Eurocentric, and this is why I'm having these experiences, or this is how it's impacting me. And then they have the opportunity to make changes as they see fit. So again, it provides a lens in which we can really, really explore the impact that our history has had on us, but both positively and negatively. And we can learn from our history what worked for us and what we need to continue to do, and what didn't work for us and what we need to work on resisting.
Thank you. That was helpful for me to be able to understand it. So hopefully it helped someone else. So going back in the chat a little bit, do you think it would be difficult for a therapist to conceptualize a client from this orientation if they don't believe that oppression is a cause of dis-ease for Black people in America?
Yes. It will be difficult because essentially the theory is saying, an assumption of the theory is that oppression is a root cause of some of the distress that we are experiencing. So again, I like to hear, when I hear that question, and I do hear that question often, I like to hear examples of an experience or something that is not tied to oppression, right? So when I hear about domestic violence, when I hear about community violence, when I hear about family conflict and, relationship issues, when I hear these things, I can attach it to some form of oppression that has taken place. And the reason that it's important for us to do that, here's an example of why it's very important to consider the impact of oppression. When we're talking about mental health in particular, mental health is something that we internalize. And so people feel bad about themselves, whether they're depressed, they have low self-esteem, low self-worth, whether they're anxious, they feel bad internally. And part of the challenges with Western theories is there's no avenue as to why this is happening. It's more, it's something wrong with you. If you change your thoughts, then you'll be better. Or if you feel this way emotionally, then things will get better. Or if you have this kind of relationship and you explore your parental and your attachment figures, then you will have this kind of outcome. When we do that, is limiting and it makes us feel like there's something wrong with us. So there's more internalization happening. Optimal theory that really considers the social context of oppression helps you to externalize what is happening. So there's nothing wrong with me, but because what has happened in my history, right? My mother may have been abusive to me, but I don't want to be angry with my mother because if I look back into history where this originated, then I'm going to have a larger context where I can understand where things came from. That's going to allow me to have some empathy and compassion for my relationship with my mother, and we can move forward and I can maintain relationships. But when we place blame, whether it's on ourselves or on our immediate loved ones, it further marginalizes us. We cut off relationships, right? So looking through the lens of optimal theory and the impact that oppression has had allows us an external view of what has happened to us as Africans and how to resist the impact that that has had on us. So I don't think that anyone can do this type of work if you do not believe that oppression plays a critical role, if not the primary role, in the psychological distress that we have as a community.
Wow, okay, that was a lot that you just said there. And going off of that in terms of racial identity, I'll come back to your question, Robert. But Dr. D asked if Cross's Black racial identity model is integrated into OCT.
Absolutely. Absolutely.
So,
Yes, because it's part of your worldview, right? It's part of your identity and how you see yourself, your view of self. And so in a larger training where we're doing this for a longer period of time, we definitely unpack cross model. And we talk about the different stages of racial identity development and how that shapes worldview. So that's where you see cross model in particular when we're thinking about or trying to understand worldview and the impact that that holds.
okay, so back to Robert's question. Could OCT be applicable to other disciplines like conflict management and industrial psychology? And if so, what could that interdisciplinary process look like?
So here's how I want to respond to that question because I don't know enough about those disciplines to speak to it. Here's what I would say. Optimal theory, what I really appreciate about it is a way of life. It's a way of being. So you can use it and you should use it personally. You can use it personally and you can use it professionally. I definitely see it showing up everywhere, regardless of what your discipline is. Because again, we're talking about institutional oppression. So when you think about industrial or organizational psych, and there are policies or procedures that are created, are they created in a way that is equitable, or do they marginalize people? So again, we're talking about systematic oppression, and how are you considering systematic oppression in those other disciplines is how I would respond to that.
Okay, people are saying thank you for your explanations and how you're clarifying in the comments.
Okay.
Let me see if I missed anything. Are there questions that you can think of that professionals who are early on in learning about theory usually ask you, or even common misconceptions about the theory?
Yeah, so I actually did my dissertation on the staff that were actually learning about optimal theory and attempting to use it. And the findings were very interesting. And so I'll share those findings to kind of help give some insight into what the process is like, and especially as it relates to early career professionals. So we're talking a lot about worldview and oppression. And I talked a little bit about how there's a prerequisite of having to understand it, live by it in order to actually do this kind of work. What I found in my study is that graduate students, early career professionals, even professionals who've been licensed and practicing for years, could not speak to their worldview. So that's fascinating, because this theory talks about the impact of the worldview and the consequences that it holds for you. But if you don't know what your worldview is, if you don't know where you fall, or if you are more suboptimal in how you kind of think and see things, or if you're more African-centered, regardless, you have to know where you are. Because if you don't, then how are you going to do this kind of work with anybody else? The other thing, what I learned from the study was that the more educated you are, the more difficult it is for you to actually believe in, receive, or understand the theory itself. So, and do you understand why that is? Because we are socialized academically to believe and to think a certain way. And so the more education we have, the more difficult it has been, from my research, for individuals to believe in the model. The other thing that I found is a level of cognitive dissonance that took place. So being here at Minority Behavioral Health Group, or going to ABPsi and other organizations and events that are more African-centered, yes, we can talk about this, and there's some harmony, and it's collective understanding, and there's agreement, and et cetera. But when you have to go to court, or you have to go to a human services meeting, or you have to sit in a school meeting talking about an IEP or disabilities with individuals, people become more uncomfortable talking about the cultural necessity of using optimal theory, because it aligns itself with what's really presenting with individuals. So then we go back to the evidence-based practices. We go back to what we were trained, right? And the reason that that's a challenge is because it places more limitations on us as a community. So for me, understanding the advice I would like to give in the insight is understanding your worldview, and how your worldview shapes how you think about yourself, your relationships, your career choices, how you make decisions, how you choose to interact and intervene with people is critical. It's like raising your own level of consciousness. And that's essentially what the skill in this whole work is about, is raising your level of consciousness. And once you're able to do that, you will be able to understand, respond accordingly, and resist the systematic institutionalized oppression that we see on a daily basis in our experiences. So having that level of awareness, which is step one, if you go back to the PowerPoint, that is important. That's why I wanted to spend time talking about step one. It's that level of awareness that is needed. Because once you understand it and you can buy into it, the rest is going to be second nature. You have to believe it. You have to understand your own experiences through an oppressive lens and see that impact in order to be able to do this work in particular.
Ooh. Have you received any pushback from other Black psychologists related to OCT?
Not directly. I have not. Again, we present every year at ABPsi. The feedback is usually very positive. We present with Dr. Myers herself. We also publish with Dr. Myers herself. So she also sends people to us to get trained. So she thinks the work that we're doing and how we are applying her model is spot on. But as far as other Black psychologists either critiquing or pushing back, I can't say that we've experienced that directly. People are usually open and asking for more training and how to get, more training. As one of the first question was, how can someone get training who doesn't live in Ohio? That's typically the feedback that we received thus far.
So I have a question, because there's not just as many white or other race psychologists that exist in the States, or that some people have access to depending on where they live. I'm not even sure how to state this, but how can people of other races or professionals or clinicians of other races counsel Black people who are affected by oppression?
You say, how can they
counsel? How can they be a clinician or be a therapist to a Black person if we're talking about using an approach like this?
Yeah.
We won't all have access to someone who's trained in OCT or.
That's right. The interesting thing is we've done this training for white clinicians. They ask for it. They think it's great because they want to be ethical and they want to be cultural. They don't want to be accused of being culturally insensitive or unethical. And so a lot of non-African American psychologists ask for this training and ask for information on how to apply this model. Now, clearly, it's not going to happen the same way or with the same impact, which is why the more we know, the more research that we put out, the more training we do, the more consulting we do, hopefully we can reach a lot of people. The fact that the ABPsi Student Circle asked for this webinar in particular is a huge first step. So the more that we can train our people early on, the easier it's going to be to transition. We've had people go on to internship and used it, and it was well received. In fact, when I was on internship, I did a grand round. I was asked to do a grand round. I was the only intern to do a grand round, and I did it on Optimal Conceptual Theory and BSA. Again, full of white psychologists, and it was well received. And so I don't think that they walk away doing the work or trying to do the work, but they do recognize that there's something else better than their evidence-based practices that we have to use. Because again, their research suggests that African Americans are not engaging in therapy or they terminate prematurely. Minority behavioral health group research says something completely different.
Thank you. So comment with a question. It's evident that this theory is transformational. How much of the process do clients take responsibility of to be receptive of their inner transformation? Or does it remain therapist-centered?
What, I missed the last part of your question.
So I'll reread the whole thing. How much of the process do clients take responsibility for, like during the therapy session, I'm assuming, in order to be receptive of their inner transformation? And then the second part of it was, or is it more of a therapist-centered approach?
No, it's not a therapist-centered approach. There's 3 phases of therapy that actually happens, but again, that's getting ahead of myself because we'll see that process in part 2 when I'm talking specifically about belief systems analysis. But again, it's a reciprocal process. What I will say is it's long-term, it's process-oriented, it's a spirit-led approach, and it doesn't happen over in 8 weeks. It doesn't happen in 6 months. I think our average stay for a client is anywhere between 2 to 4 years. And we have clients that stay longer. And it's not necessarily that they're staying because they have a mental health diagnosis. They stay because they're being fed spiritually. Their consciousness is being fed. So they're learning, and it's very liberating and uplifting. So that's why they come back. And so it's their process that unfolds. And while their process is unfolding, the therapists have their own process unfolding. So it's a simultaneous thing that's happening between both the therapist and the client at the same time.
Would an example of OCT be a person that takes the EPPP and fails the exam the first time, and their experience of the symptoms of anxiety that they experienced during testing preparation were a result of something oppression-based?
I would love to know who asked the question, because I can relate to that question. That is a great question.
I'm not sure if that's the answer now.
That's a great question. And here's what I would say. If you choose to view that through that experience, it will lessen your anxiety and it will have you to do something different that will allow you to move forward and go and pass that exam. And that's the process of it. So if you see it as an oppressive process where we know that African Americans are not passing that test on the first time at a higher rate than white people, then we can look at it as an oppressive process, right? But it doesn't stop there. It's how do we resist it? What do we do to overcome? And do we then think we are less than because we can't? So what is the impact of that? Do I now think that I'm not smart enough? I'm not good enough? I can't become licensed as a psychologist? What is the internalized process that you're holding as a result of that? Is how we would try to work through that level of anxiety so you can go ahead and pass that exam. That's my favorite question of the whole night.
Really? And it kind of led into what you just said about does it make you not feel like you're good enough to be a psychologist? Because the second part of the question was that they're still trying to conceptualize does it contribute to the underrepresentation of Black psychologists and or the worldview that Black people are uneducated?
It very well could. Very well could. Because again, here's the reality. We live in a world where there is oppression. It is systematically set up that way, right? The challenge is do we internalize it? Do we fall victim to it? Or do we do things differently that's going to uplift us and our people? Like, that's what it is. Oppression is there. Am I going to internalize it, or am I going to resist it by raising my level of consciousness, by believing in who I am as a person and what my purpose is and who my community is, and right? So That's how the work unfolds.
Okay, next question. One, yes, that question was directed at you, Norma. But the question that was asked is, in undersourced communities in LA, MFTs and social workers also work with Black clients. And this person is wanting to know if Dr. Meyer's theory and your training is reaching them as well.
It could. Here, Dr. Myers will say that this theory is universal. It doesn't matter what your ethnic background is. It's applicable to everyone. And here's why. Because essentially what we're talking about is a worldview, right? A worldview that's considered universal, that originated on the motherland, like that we're all can obtain. Anybody can hold an African-centered worldview. Anybody. And so because that's her position and that's what the reality is, then it's really applicable for anybody. If you want it, if you believe in it, and that's the work you want to do. Mm-hmm. So it doesn't further marginalize people. In fact, the motto is talking about marginalization of people. So it's not going to marginalize people. In fact, it's to get people back to a point of operating where things were collective and unified and interpersonal and in harmony and rhythm and etc. We just got to get back there.
Any more questions? There's a comment from a friend of mine and colleague who interviewed at the University of Akron years ago, and they said that they visited the clinic and the atmosphere of the clinic was welcoming, and as a Black therapist, it was uniquely Afrocentric and validating.
Oh, good. That's because we have 2 African-centered ABPsi psychologists over there at the University of Akron. Well, there's 3. So yes, the University of Akron is well represented with Black psychologists. So that's good to hear.
Nice.
Mm-hmm.
Any other questions? What advice would you give to a graduate student? This is not my question, but a graduate student matriculating through a psychology program who is forced to learn only Western therapeutic orientations. Oh.
Yes, that's common. I know that was my experience, and I think that's pretty much all graduate students' experience. And it's interesting because they make you choose. I know my program, we had to choose CBT or psychodynamic, and that's your track. Your practicum had to be in that track. Your internship, you had to tape sessions. So I had that experience. And again, I would also talk about how I see clients in supervision through optimal theory, and I would speak to the research. So again, I think one of the things that's very important for us is to know the research. And if we can talk about research specifically with people of African descent and what works and what does not work, then it gives us credibility and we can have those discussions in our graduate programs. But the programs, I don't know if there's a way around us not choosing a theoretical orientation. Again, this is why on step 1, the awareness slide, you have to understand the training and the theoretical orientation that is being forced on you. And I say forced because that's just what it feels like in graduate school. And once you are aware of that, and you can speak to the limitations of those theories, what the research say about those theories and people of African descent. You also know what the research say about how to effectively work with people of African descent. You can then have those conversations with your supervisor or with your peer groups and et cetera when you're in graduate school. I know when I was on internship, not only did I do a grand round, but when we have to do the peer article review, we would go and we would have to share an article. My article was from the Journal of Black Psychology on how to deal with Black people. So giving them the literature and the research, it gives you credibility and it protects you, hopefully, from any other forms of oppression that they may attempt to press upon you.
I'm wondering for you, since you worked at you interned at the VA or worked at the VA, and
Mm-hmm.
have that approach, you were using that with your Black clients, and then what about your clients who were of non-African descent? Did you use a different approach, or how did you approach therapy with them?
No, so, and I practice now. So I'll answer that question, but I'll answer the question on how I practice now. And regardless of who I have in the room with me, I use the approach because it works. And I'm talking about a worldview. And usually when I'm working with people who are not of African descent, they are of low socioeconomic status. So they are impoverished, right? So when I'm talking about oppression, I'm talking about it from that lens as it relates to classism, and then how they've internalized the messages as it relates to that set of circumstances for them. Now, when I was on internship, that's very different. And here's how it played out, because we have to tape sessions, right? So you tape your sessions and you have to demonstrate competency. And what I had to demonstrate competency in was cognitive processing therapy, prolonged exposure therapy. Those are the trauma-based therapies that I was on the rotation for. So I had to demonstrate, or motivational interviewing. I had to demonstrate competency in the theories that they wanted me to demonstrate competencies in. But in supervision, I would be able to talk about how optimal theory would see those same cases. So I was limited as it relates to how I worked with the clients because I was being recorded for competency evals. However, I would be able to talk about it in group supervision or in my individual supervision, which is how I was invited to do a grand rounds on it at the end of my internship. So I don't vacillate between theories given who I'm working with. It's pretty much what I do and just how I see things in general, which is, that's been 10 years. That's been a 10-year process.
Yeah. That makes sense. I think for me, I'm more asking because I'm going to be approaching the phase where I'm going to be on internship, and I'm still a young clinician. So I'm even trying to learn the theory that I'm, interested in honing in on now. So just trying to think about how I'm going to maneuver that when I get there.
Here's one of the things I will say. And so we have a lot of practicum students that get trained at MBHG before they go on to internship. And for some of those students, when they write their essays, they talked about optimal theory and how they use this theory to conceptualize cases and et cetera. And for some of them, and then one person in particular, it got them a very well-known, excellent, top-rated internship. And so we've had students here who've actually talked about optimal theory in their essays and in their application process that got them interviews and got them internships that they wanted, and it worked well for them. So for me, that says that people are open to it and people want to hear things differently, especially when you can point out the limitations of the things that we are often saying is evidence-based, and this is what we need to be doing. If you can point out those limitations and offer an alternative, people are more willing to listen.
Also, I know you said that you're willing to share the slides. I'm wondering which email you prefer people to email, the ABPsi one or your MBHG?
The MBHG.
Okay, so I'll share that with them. And then the part 2. They want to know when the part 2 is. I think we were trying to schedule that for next month, probably before we jump into another one. So
I have it. It's on my calendar already. Do you not have it?
Yeah, so I mean, we have it. So I was just going to confirm with you to make sure.
Oh, yes. I have it on it. I think it's the last Tuesday in February.
Yeah.
Yeah.
So yeah, we'll send out that update for you all to be aware that that's coming up. Dr. Lodge, did you have anything else you wanted to share?
No, thanks. I think the questions were great. I think a lot of the questions will be answered in part 2. I just wanted to really focus and emphasize on the theory, because the theory is what's going to drive the therapy. You can't do the therapy without really understanding or believing in the theory. So I want to limit today to the theory only. But a lot of the questions that were asked is really based off of how the therapy works. And so hopefully you'll get more insight into that next month. But thank you all for having me and having this format. I think it's awesome. We're always willing to train and consult and provide supervision and do what we can to get it out there.
Yeah. Thank you. Thank you so much for doing this for us. And we look forward to the part 2 next month. And just like a few last announcements. So I'm Robina, I'm the communications chair. So if you have any questions in regards to webinars, past ones, if you want to get any of the information, you could email the scommunications@abpsi.org email. Or if you have general questions, I'm putting the email to the chair and the chair-elect. And then if there's any students online, we're looking for campus representatives at different universities. So please reach out about that. And then lastly, the convention is coming up this summer, and the call for presentations, the deadline for that is February 15th at 5 p.m. So please submit something. This year's theme is African psychology and Afrofuturism, psychological liberation and spiritual illumination. So if you want to see what you have to share with us as well. That's it. If nobody has any other questions. All right. Thank you. So yeah, Dr. Lodge will send me the slides and I'll send them out to the listserv. And if you're not on there, you can go ahead and email me directly. Bye.
Bye. Thank you.